And John, I'll let you start.
Great. So good afternoon and welcome to our 5th webinar in the series brought to you by the Dental Community Resource. A warm welcome to those of you who are returning, who've joined us in the past, and for those of you who are new, we've embarked on a series of webinars on a weekly basis, which we've titled Tuesdays at 2, to try to synthesize information as it emerges, bring to you the latest information that's available to us, particularly here in the province of Ontario, and share with you any news that we have that we are trying to make sense of for you. Next slide, please. On behalf of Manor and Steve and the rest of our Dental Community Resource faculty, next slide, please. The whole team of people who we work tirelessly behind the scenes to put together the information that we're sharing with you today and we have in the previous weeks. These are some of the faculty that you've met since we started our programming a year ago with continuing education programs, and here are some of our staff who've been instrumental in communicating with you and helping us get organized for a program like this. Next slide, please. Just an update on the sex distribution of new COVID cases in Canada as of April 20th at 11 a.m. You can see that the largest number of patients with testing COVID positive continue to be in the 50 to 59 age range, and these numbers have been fairly consistent throughout these 5 weeks that we've been together. Next slide, please. It gives me great pleasure to welcome back our dear friend and colleague, DCR faculty member, Dr. Manor Haas, who's going to spend time with us this afternoon, focusing particularly on defining and managing endodontic emergencies in the COVID age. Manor, the floor is yours.
Thank you very much, John, Steve. There's also, I call him the ninja in the background, Woody Bongard, who's helping us put all this wonderful technical stuff together. Thanks for joining me. You may have heard me last week also about my experience. Really what I want to talk to you colleagues about is us as wet-fingered clinicians during this COVID era. What do we need to know? How do we triage patients? What is an endo emergency? What's not? What about aerosols, rubber dam, and endo? And then what should we or could we do about our offices from what we know? Even though nothing I'm saying is etched in stone, this is so fluid. So it's like you can run out and quote Manor on it, so to speak, or DCR, because things are changing so quickly. But putting all that together, I want you to keep in mind as we move along with this presentation that I want you to think about how at the end, what recommendations we'll put forth and how to move forward. So from the information I'll provide you, start thinking positively about the world of dentistry and how to move forward. So nowadays you wake up in the morning and, you know, I'd ask you, okay, what day is it today? And you might say, I don't know, is it Monday or Tuesday, or was it yesterday or tomorrow? It's become like that. That's our life nowadays because so many offices are closed in North America, if not most. However, keep in mind today, literally today is the time to start planning, about what to do. If I presented this thing a week ago, my tone would actually be very different. That's how fluid this is. Now, today, I'm going to be starting to talk about, let's start to seriously plan for maybe opening up carefully. How exactly? No one knows yet. But I want you to have that positive thinking in the back of your mind, cautiously moving forward. So very quickly, guess who's at the front in terms of being at the highest risk for COVID-19? There was an article on March 15th in the New York Times, and of course, you guessed it, we're at the top. You could see at the top right, us and our staff and our hygienists, we're at the top. So with that in mind, we need to remember that as much as things are changing, there's one thing that's become a common theme in the past number of weeks, and that is for that, at least for the foreseeable future, dentistry will involve mainly emergencies, and that mainly involves endodontic emergencies and oral surgery emergencies. Sure, there'll be some restorative here and there, but it's mainly patients in acute pain or swellings, that sort of thing. That's a common theme, and that's what we need to keep in mind for the foreseeable future. However, these emergencies are starting to pile up. These poor patients of ours, there's only so many weeks they can hold off with antibiotics or Advils or whatnot, or their acute pain. So we need to start thinking ahead about what do we need to do? Is it an emergency? Is it not? And how do we manage it? So first, to start off, defining what's an endodontic emergency and what's not. And I'll try to keep this sort of broad, just for the sake of time. But what might not be an endodontic emergency? In other words, a patient that you might not necessarily need to see. A lot of this has to do with clinical judgment, and a lot will have to do with you first screening the patients by phone. You're not going to, you're going to try and limit the number of patients that you see or your staff see in person, and you might not be able to see them in person. So when you talk to them, at the very least, there's a lot you can do verbally in terms of diagnosing. Ask the patient, what brings on the pain? Well, if they say that that pain comes on in the middle of the night and it wakes them up, and it's not one tooth, it's the whole area of their mouth, well, maybe it's not an endo. Maybe it's them clenching or grinding. If you have access to their chart, you might know they've got a history of clenching or grinding. That's not an endo, don't bring them in. If it's something where maybe it's sinus related, those sort of things, that's what I mean. Or if it's a case where they say, I've had this pain, doctor, for the last 3 months and I just want to deal with it, that's not an endo. Or if it's something that could be managed with over-the-counter medications, Advil and or Tylenol, or maybe a prescription for Tylenol 3 or an antibiotic, if you can carry them over that way, and certainly it's not life-threatening, then you would want to try and hold off on that. So this is just a rule of thumb. You got to use it case by case, clinical judgment. Your patient. Some patients, their tooth could be broken off and they'll say, I'm fine. And then you have other patients where they chip 1 millimeter of a tooth and their life is over. Your patients, you need to gauge that and keep these sort of things in mind. On the flip side, the more important thing is trying to figure out, what do I need to see? What is an acute endodontic emergency? Again, it's case by case, clinical and personal judgment comes into play. But in terms of an acute scenario, in general, it's ones that over-the-counter medications cannot manage. So you got to keep that in mind. It's one where this patient maybe came into you and they said, holy cow, you know what? I can't sleep. I've had this acute pain all night long. It's kept me up, but Tylenols, Advils don't help. All these things, that's significant. That's a case where you need to keep in mind that you might need to see this patient. Advils, Tylenols, antibiotics, they're not helping. It's an 11 out of 10 when you ask them how bad it is. Or they say, I drink a little bit of cold and hot and holy cow, I'm in agony. It's starting to sound like it's an endo. And so you start gauging and triaging those patients. Or if they say they have a swelling. Now, when patients tell me over the phone that they have a swelling, with all due respect, I don't believe them, because very often they say, I've got a swelling. They feel like they have a swelling, but they may not have one. So ask them over the phone, look in the mirror, please. Is the right side looking like the left side or not? If one side looks bigger, okay, you may have a swelling. So you know what I mean? You need to gauge these things, and you can pretty well start to tell verbally already what case is acute. If you did a deep restoration just before COVID, and now that tooth is in agony, it's probably an endo. If there's a crown fracture, an avulsion, some sort of a trauma to an anterior tooth, again, that's something needs attention immediately. What I do want to mention is you do not refer your patients to the hospital ER. You do not do that, because that's sending them to where the nuclear reactor is. Okay, when I was a patient a couple of weeks ago in a hospital with my personal situation with COVID, I was that nuclear reactor. I was in the hospital with COVID patients. You do not send them there. So you need to keep in mind, who do you need to see, who do you not need to see? And this is where this whole DCR, if I may, comes into play so much, because reach out to one another. Reach out to us. Is this significant? Is it not? Everyone is there for each other for support.
Manor, if I can interrupt you for a second.
Oh, please, Steve. Yeah, go ahead.
Yeah, I'm wondering, how do patients, and I'm sure others are wondering as well, how do patients react when you disagree with their degree of urgency? I know that we're facing that a little bit as we're screening kind of strictly, and I'm wondering how you're reacting.
Yeah, great question. I actually had a patient I had to get on the phone with, because my receptionist could already tell it's not an emergency. She had a scenario in her case where she's had a tooth that needed a retreat. It's been since January, so it's been for months. She's not really in pain. Actually, she wasn't in pain, but her insurance was about to expire. So whether it's mild pain or the insurance is about to expire, I had to get on the phone personally and say, listen, it's not up to me. Our regulatory bodies and even our government is saying we need to be very careful and specific about who we treat. I'm sorry. And this is all very politely, but that's how I do it. So it's a great question, because I'm sure many of you are facing this, and more because patients can only hold off for so long. So thank you for asking. I would recommend you go on some websites for resources. The American Dental Association website, I got to give them credit, is phenomenal. Here's a flow chart for you to try and figure out, okay, is it an emergency or not? So stay up to date with these websites on the Canadian side and the American side, but stick to the credible websites. So moving forward, what does it mean to you, the wet finger dentist? Well, the main thing we find is aerosols. If you have to do a procedure, the key is to try and reduce or eliminate, if there's such a thing, producing contaminated aerosols, meaning aerosols that are contaminated with saliva, blood, that sort of thing. And this is mainly to do with high-speed handpieces and ultrasonics, endodontic ultrasonics in this case. The other thing, and I'll touch upon this a little bit more in a moment, if let's say I have an endodontic apical surgery case that needs to be done, I'm not going to be doing that. I'm going to hold off as long as I can, because as you can see in the video, if I'm doing an apical surgery, my ultrasonic needs water, but it's also in contact with the patient's blood that's contaminated, and maybe saliva, even if I give them chlorhexidine beforehand. So that sort of procedure, I'm going to hold off as much as I can. If on the other hand, you have to do a maxillary molar endo, and this is, again, as I give this information, I want you to think about you yourself potentially going into your office. No one has said you can't see patients, so long as you follow careful protocols and screenings. There's no one saying that that's it, the doors are shut in the world of dentistry. So these are informations that we are giving you guys, and I'm giving you folks, pardon me, in terms of what if you do have to go in? Your patient can only hold off so long, and there's no endodontist in your area. So with that in mind, if you're doing a maxillary molar endo, and you need to groove the floor to find the MB2 canal, or any canal for that sake, well, very often we used to say use an endodontic ultrasonic, but that produces a spray. Well, maybe you want to now then consider using a slow speed handpiece with a surgical length burr, a round burr. And while you have bleach inside the pulp chamber, use that instead with, of course, the high volume suction still right there beside the tooth. So you may need to think about sort of modifying things a little bit. In terms of aerosols and splatter, in 2004, in the Journal of the American Dental Association, a peer-reviewed, fantastic journal, and this article written by very respected people, they were way ahead of us with this. They already looked at aerosols and splatter, and this holds true today. The bottom line from this article, which also mentioned that just using high volume suction, just for you to know and to share with your patients and to put your staff at ease, high volume suction alone reduces the aerosols by 90%, right there, for regular procedures. What their bottom line was, use universal precautions. So in other words, things are no different. Use universal precautions, gloves, masks, eye protection, that sort of thing. They already recommended back then, and we're hearing this more and more nowadays, that patients should be rinsing their mouth beforehand with chlorhexidine to try and sort of lower the contaminants, and then use rubber dam when possible. Well, in endodontics, it's not when possible. You're going to be using rubber dam at all times, period. And so that already keeps saliva and blood and that sort of thing that's around the tooth out of the way. And the high volume suction, as I mentioned. So it's a good study to look at. So when it comes to aerosols, again, for you, if you have to go into your practice tomorrow morning to see an emergency, so long as you're using the right precautions, as we're being told to use with our regulatory bodies, fortunately, in endodontics, it's, well, if I can say this, it's fairly easy, or easier than the rest of dentistry, because you must use a rubber dam for isolation. Now, that's always been the case, but now I need to stress it even more. You're not going to do an endo procedure on a patient with the X over her mouth because you got saliva in the way and that sort of thing. You're going to put a rubber dam on there, and it stays on there. And if anything, now what we do in our office is we put the rubber dam actually over the patient's nose also. And then what we do is essentially what we're doing, if I may, we diagnose the tooth, we give the patient chlorhexidine to rinse their mouth with for at least a minute.
Manor, I'm just going to ask you, because I know many people are going to be thinking of it. As we watch more and more of this stuff coming from Asia talking about their precautions, they're mentioning iodine and peroxide rinses. Any comment about that versus Chlorhex?
Yeah, I'm not the expert at, bacteria and viruses and whatnot. hydrogen peroxide alone, we've never been a fan of in endodontics. Chlorhexidine kills more bugs than that. The combination of iodine, we're still learning about this virus. So it's a good question. And this is where later on, I'll also say stay up to date because we're learning more and more and more. So it's a good point. And, Asia might be ahead of us. They know more than we do. They've gone through more, unfortunately, and maybe the same with Europe. But just as a rule of thumb, and this might be chlorhexidine today, and in 1 week, I might recommend something else. But just keep in mind contaminants, chlorhexidine rinse, anesthetic, rubber dam goes on right away. And then what we do, and what a common theme is then you rinse the tooth before you've accessed it with chlorhexidine or bleach, which is what we do. And then you access the tooth. And as soon as you access the tooth, there's bleach already as an irrigant in there, not RC prep or anything like that. So, and there's of course high volume suction at all time. And until the tooth is restored, we're not taking off the rubber dam. And so for the x-rays, just as a little tip for everyone, leave the rubber dam on at all times, of course. Legally, you need to do that anyhow. But also leave the frame on because when you take the frame off, the outside of the rubber dam often gets contaminated with saliva and it gets messy. Leave the frame on. There's always a way to do that, as you can see here in the photo. The other tip, if I may, is that patient of yours that doesn't want to be in your chair for that long. And the same with you. You also don't want them to be in your chair for that long. And so being efficient is extremely important. And so a little tip is use an apex locator if you're not using one so far, because an apex locator will let you determine the working length better, but also more efficiently, and hopefully you'll need less mid-treatment films to confirm your length. The other tip is, again, while we're on the theme of being efficient, you want that patient sort of in and out. One of the concerns dentists have, and we know through our focus groups in DCR, is when we go back to practice, we're not going to see the same volume of patients. So let's be honest. If we can make the procedure, if we can keep the same level of precautions that we need to or are advised to, but be more efficient and biologically, clinically still perform the same procedure at the level we need to, there's nothing wrong with that. And then maybe we can see a few more patients during the day. So being efficient is very important for many, many reasons. And that goes into play when it comes to instrumentation. I would strongly recommend you consider using endodontic filing systems, NiTi systems, like the very popular Wave 1 Gold from Dentsply, or the one that was recently released from Brasser, the ESR, which is sort of a copy of that same idea, where one file could do most of the work, maybe all, and do the work of 3, 4, 5 files. You don't want to be starting to play with 1 million files now. This is where you want to be efficient. The same with obturation. On the bottom here on the screen, the middle photo is where it's a warm down pad, vertical backfill, multiple steps involved, more things can go wrong. During the COVID times, maybe it's not a time to start playing with this unless you're really proficient at it. Maybe using Guttacore, the popular Guttacore system, the single carrier on the bottom left, might be better if you want to do warm. Or this might be a time to temporarily, just for now, during the COVID time, think about customized single cone obturations like you see on the bottom right, but customized to the file. And then when this whole thing passes, then go back to warm obturation, which is the gold standard. But it's what you take out that matters, not what you put in as much. So think about being efficient nowadays. The other thing is, if you cannot finish the procedure and you can only do a pulpectomy to get your patient out of pain, no problem. But you need to medicate that tooth with calcium hydroxide, like you saw in the bottom right video, where now there's calcium hydroxide in the canal. And a really important thing, and what we're doing in our practice, is because we don't know when the referring dentist, or in this case you, might be able to restore the tooth permanently, instead of putting cavit in there, as we've always done, where we know the patient will be seen in 2 weeks or so, what we're doing is now we're putting a permanent restoration. Very, very important to keep in mind. So moving forward, let's be positive here. A week ago, I would not have had this slide in there. But now you start to hear about Pandexit. What do we do moving forward? Let's be positive. It will end, but moving forward could mean you seeing a patient tomorrow morning, or it could mean that you essentially maybe planning for a month from now, 3 months from now, whatever it might be. Today is the day for you and our colleagues to start thinking, what do I do now? And how do I plan ahead? versus just sort of thinking, looking at the news and the numbers and, oh my God, it's going to go on for this and that long. And no, it's a time to be, if I may say, having survived COVID, it's still a time to be positive and optimistic. I really believe in that, but we got to be careful. So when you look at some websites out there, such as the American Dental Association, this is really fresh. And John, you shared this with me, and I appreciate that. Just yesterday, you shared this with me. This is what I'm saying. It's amazing how things change, how things just every day they keep changing and changing. Already there's talk about just the interim sort of guidance for some states and provinces. Soon enough, we'll hear about provinces starting to reopen. There's just whispers of this. The state of California is talking about this too. It'll trickle its way up the border to Canada too. But keep in mind, as the ADA is saying, and I agree, the following: the ADA recognizes that the local or state, in this case provincial governments, their decisions regarding closures, including restrictions regarding elective healthcare, that supersedes anything that the ADA or the CDA, in our case in Canada, or the ODA might say. So keep that in mind. In the end, no matter what some people might say, what organizations, what dental societies might say, it really, you have to keep up to date with what our governing licensing bodies say. Very, very important to keep that in mind, especially as things change. Steve, John, I mean, when you gave your webinars 2 weeks ago, did you even imagine we'd be talking about now actually opening up this soon?
Sometimes on Monday morning, I can't imagine what we're going to be talking about today on Tuesday. Like it's really changing so rapidly. I was just thinking and making notes to myself that, I think a great topic, John, for 2 weeks from now might be all these recommendations that are starting to creep in from Asia. Maybe we can comment what's real, what's false, what's being followed up. I think we need to put some kind of clarity on the ground with all this. That's how fast this is changing.
Right, and I agree. Sorry, John, yeah, go on.
No, just add it. I mean, it takes a special guy like you, Manor, to have gone through what you went through to be the voice of optimism. I love it, and I'm sure our community really share that spirit. I think there's a lot of information. I think as we start week 6 of this process, people are obviously feeling very restless and anxious to start moving. Spring is definitely in the air, and so things like that are definitely inspiring. I think the message is the right one. We definitely have to make sense of this information because we don't want to rush to decisions that may not be indeed what's going to be asked of us. But it's really important for us. It's what our commitment has been to this group, is to be aware of what's happening in other places south of the border and other parts of the world.
One of the fears I have, Manor, sorry to interrupt, and I'll be brief. One of the fears I have is we're going to be inundated with a bunch of products, many of them lousy, many of them untested, just all trying to, follow up on our fears and take advantage of that. So I'd really like an opportunity to maybe try to assess this independently if we can and get back to all of you with regards to our findings.
Yep, sure. And I agree with you, Steve, completely. Dentistry is a big business. Yeah, what an opportunity this is for businesses. And, in the end, it's us trying to refer to credible sources. if someone talks about a virus, I think I'm going to trust the Centers for Disease Control or Health Canada more than some wishy-washy sort of, Instagram posting or heaven knows what. So we need to be careful what we do, how we do it. But it is incredible how it's changing and how now you hear a little bit of, I really see it as careful optimism. Now, moving forward, again, I want everyone to think about moving forward. It's not just, I'm closed, that's it, I don't know what day of the week it is. No. It's very important to now start keeping in mind also the important people for us that run the practice. And we might be worried about patients coming back. What's more important, I find, is our staff. Without our staff, we're useless. So everyone is at risk of catching this, including, of course, our staff and us. So we need to be vigilant. But what's really important is our perception. It's not just the facts. Yeah, N95, we're screen patient. But if you happen to have one staff member that's getting their information from who knows where, and they're paranoid for all the wrong reasons, if I may, with all due respect, they're not coming in and that's it. Your office may not open up. Even if the patients are lining up and they're ready to come in and the government says you're okay, you're obeying the regulations. So stay close to your staff, give them more information, give them support. The more facts they have, the less fear there is. So be in touch with your staff by Zoom, or Google Meet, or by phone, whatever it is, or by text, but stay close. Now, again, moving forward, what I see, and this is changing, I find, and I can't give you an absolute answer, but I sort of consider the times now as being universal COVID precautions that we have to take into account. In other words, we've always had universal precautions. Nothing's changed. I told my staff even, nothing's changed, except for now we're adding more precautions. But otherwise, we're wiping down the rooms the same way, sterilization the same way. I need to reassure the staff and remind them, we're doing the same thing, but it's COVID precautions. Of course, it's all about PPEs and using the right PPEs. And the question is, what is the right PPE? Do you need an N95 for everything? Are there aerosols, no aerosols? If there's no aerosols, maybe you don't need that. Maybe a level 3 is enough. And I keep saying maybe because things keep changing. Again, next week it might be different. In terms of eye protection, now maybe you need to be even more careful. In the bottom right photo, you see my colleague, Riley Lewis. He's actually got eye protection that seals around his eyes completely. Our assistant, you see, has got a face shield. Who would have thought about this a month ago? These photos are already outdated. These were fresh right after, or as COVID was getting bad, and before all the regulations from the college and all that. Now, everyone's wearing an N95 mask and possibly another mask over that, in terms of putting a head cover also. So it's interesting how just within a few weeks, these pictures are already out of date. The other precautions, and I'll spend just a few more minutes talking, are we screen our own staff, and I document it, take their own temperature, oxygen, pulse oximeter sort of thing in the mornings. We document it, make sure no one's got symptoms, but we also do the same for patients. When we do it by phone, and we do it as soon as they come into the office. And now we're also seeing one patient at a time. So before they even come into the office, they see a sign like this. And again, I want you to think about, what do you do in your practice? And the logistics are different for every practice, but I want you to start thinking ahead about what you could do now if you see a patient tomorrow morning or in a month. So this is what we do. We tell them, don't come into the office until we call you, or call us when you're at the door. The moment they come in, there's a second door they come, there's another attention page from the province. And then when they come in, right away, what we do is we put a mask on them, tell them to sanitize their hands, put shoe covers on. We take their temperature right away. We even use a pulse oximeter. I mean, this thing over here is what saved my life. That's what told me, Manor, your oxygen is really low. You need to go to the hospital. So we do that. We document everything, and we have them fill out a specific questionnaire for COVID, separate from the medical one. And you can see on the left side, the patient is there, mask is on. Even if they bring in their own gloves after the pulse oximeter and they put back on their gloves, we have them sanitize those gloves too. And on the right-hand side, you see the patient is always wearing a mask, and they're wearing it properly over their nose and mouth. So when they're at the reception area and the receptionists are also wearing a mask, if they cough, at least we're not as worried about air droplets. Now, we don't have the plexiglass there. Everything's on back order. I don't know if you need that. If the patient is always wearing a mask, John, Steve, every office is different. I don't know how your offices are laid out specifically. What do we need to do in terms of the physical modifications? Do we need this?
Well, the question, I think, Manor, the question of need is going to be, not an easy one to answer. There might be no need from a true virology point of view, but there might certainly be the need from a patient perception point of view. We're going to have to get our staff back and feeling comfortable, and our patients back and feeling comfortable. And that may not have anything to do with the regulations that come back.
Right.
Like, there's a lot of different factors that we need to consider in this.
Yeah, and I 100% agree with you, that perception idea completely. That's why we even tell patients what we do with precautions before they come in. So when the other modifications very quickly is we used to have magazines in the office. Well, we took care of those. We moved them away. The water cooler is already now in the back of the office. We used to have chairs side by side, and those chairs used to be packed. Well, now it's fewer chairs, more space between them, gives the patient a sense of perception that, good, there's more distance now. And then one other thing very quickly is we, for the last couple of years, have used this air filtration system which is way above and beyond the HEPA filter. It also clears viruses, and it's a very high volume system. It happens to be surgically clean air, and I know they're in back order. So there's all this talk about what we need to do, don't need to do. I don't have the answers because it keeps changing, but start thinking about what you could and should do to try and make it as safe realistically, but also perception wise, and stay up to date with websites. So we talked about a lot of things, but I want you to think ahead about how do we open up now, carefully, cautiously, and according to the regulations. But I do see optimism, careful optimism there. So I'll leave it at that. John, I know you wanted to spend a little bit of time. Just if I may, we're here with one another. Give support, receive support. Don't be shy to ask for help, okay, whatsoever. That's what we're here for.
Thank you so much, Manor. That was a terrific synthesis of where things are at. I think it helps provide a very useful scaffold for our dental community members to things to be thinking about as they're taking care of emergencies and understanding that these measures are evolving in time. We also wanted to share with you, Manor, Steve, and I, that we started our focus group conversations last week. We've had the pleasure and privilege of interviewing about 35 actually dentists in the community who have helped us in better understanding the needs and concerns of the community at this time. We've offered an invitation to meet with you informally via group discussion to really hear what's on your mind. The goal here is to spend about 30 minutes together discussing your concerns and how this dental community resource could be supportive of you in this unprecedented time. If you're interested in joining us, we'd encourage you to please sign up on the link available in the YouTube description for our Tuesdays at 2, or go to our homepage and there's a specific link that you can click on. One of our goals, Steve Manor's and mine, and the rest of our faculty and the rest of our team, is to get a sense of best practices as they're emerging, recognizing that they're changing. It's a very it's an environment that is literally changing so rapidly, but we want to try and stay on top of that for you. With that in mind, we thank you for joining us again today for Tuesdays at 2. Please be well and stay safe. And if you need information, everything continues to be posted on our site. Look forward to seeing you a week from now on April the 28th for our next Tuesdays at 2 session. Thank you so much. Bye-bye.
Thank you, everyone. Stay healthy.
Take care, everybody.